So this is a real problem. You say, am I just making this up? Does this really happen? Well, when we developed this cystine assay at Lithuania, I asked this question. How often does this happen? Now, this isn't the data that David showed you. This is the more recent data I take from Lithuania of people who just send in urines to us. Cystine patients who send in urines. Okay? And what we do, and some of you have done these studies for us, so you know it's a bit of a nuisance, and I apologize, but I don't know how to get around it. You collect 24 hours worth of urine. And we have patients take and pour off a little bit of that urine into a tube. And that's the cystine at the what's so-called ambient pH, the pH of the urine, the natural pH of the urine, whether it's 6, 7, whatever it happens to be, whatever that person's urine pH is. We get a little bit of urine for that, little sample. And then we give them a compound to change the pH of the remaining urine, that 3 or 4 liters of urine that they have. We have them dump it into the container, mix it up, let it sit for a while. And the urine pH goes up to 10, higher than any human would ever get you in urine. But when you get urine pH up to 10, cystine becomes tremendously soluble. Any cystine that precipitated during that 24-hour collection will dissolve. If there's been significant precipitation, the cystine at the alkaline pH will be much higher than it was at the ambient pH. All right? So look at this graph. Only one point I want you to take from this graph. If crystallization has occurred, the point in a specific urine sample, the point will be above this diagonal line I've drawn through the middle of the graph. Now you'll see a lot of urines, it's fine. But you'll also see a significant number of urines where crystallization occurred. And the sample, if it had just been measured, as it is in most labs just routinely, the cystine that person excreted would be tremendously underestimated. If you look at this person, he had a cystine concentration, a real cystine concentration of 1,000 milligrams per liter. What would the lab have measured? About 350 milligrams per liter. About 1/3 of what it really was. Now, at Lithuania, we don't have people refrigerate their urine when they do a collection. So I got a crowd here. I'm going to ask the question. How many of you have ever been told to refrigerate your urines when you do the collection? All right. When you refrigerate the urine, even more precipitates out. And the artifact gets worse. So why do doctors call me? Because they say, you know, I got a cystinuric patient, and they were excreting 500 milligrams a day, and I put them on alkali, and I told them to drink more water, and they came back, and they got 1,000 milligrams per day. Well, the answer is, you treated the patient appropriately, and now they no longer crystallize their urine during the collection. And their real excretion rate was always 1,000 milligrams per day. You didn't do anything wrong. The patient didn't do anything wrong. The lab screwed up. So you want to recognize this is a potential artifact. You want to know the full excretion rate of cystine. It becomes less of a problem as therapy becomes effective because you actually do get the right number. Next slide. This is a slide from those same patients, a graph of actual cystine excretion. I want to show you this because I want you to see that not all cystinurics are the same. You have different diet intakes, your different body size, different age. And there's a wide range of cystine excretion from 500 milligrams a day to over 1,500 milligrams a day. It's useful to know how much cystine you actually do excrete because you want to know how aggressive your therapy has to be. Obviously, the person who's got 1,500 to 2,000 milligrams of cystine a day needs a whole lot more aggressive therapy than someone with 500 milligrams a day. They need to drink more, they need more alkali, they're probably going to need thiola or something else like it. So just finding out how much cystine you excrete can guide your therapy at the time you first start seeing the physician. You know, I view it, when I see somebody, you know, I don't see very many kids, but I do a couple, but mostly I see adults. You know, 500 milligrams of cystine a day, and they form cystine stones. I mean, I can tell that person, if you will just drink enough, you don't need any of these nasty drugs. If you'll do it. Versus this person, who I know, I'm going to have to push a long way. So it's a very useful number, just to even get your starting point. Next slide. Now this is a confusing slide. I just want to make one point. This is the cystine excretion versus the urine volume per day. When I tell these people, you got to make 3-4 liters of urine a day. Especially the first time you meet somebody, they often look at you like, 3 times more than I make now? That's impossible. Well, look at that. If you do a line from 4 liters, a lot of people can do it. So I commend you for your hard work, and I use people who are successful as the example that this can be done if you're willing to think about it and sacrifice. And obviously, there's a rare person who makes 8-9 liters a day. One of my patients makes 8 liters a day. He's taken himself off Viola and alkali. He'd rather just make 8 liters of urine a day. He doesn't have stones anymore. So if you can do it, congratulations. But there's an inspiring, significant number of people who can do it.
Is there a relationship between urine volume and cystine excretion?
Well, yeah, I think the only people who really get the high volumes are the ones who have higher cystine excretion. But there's certainly some people down here who are failing completely to get their urine volume up, especially to the level of cystine they excrete. All right, David showed you a graph that looked very much like this. In addition to increasing urine volume to keep urine cystine concentration low, you can change cystine solubility. Cystine solubility is the amount of cystine that can stay in a urine before it crystallizes. And David showed you this and showed you that as urine pH goes up above 7.5, cystine solubility increases greatly. Most urines, normal urine sits around 6, which is a low point for solubility for cystine. Generally, this is a guide to therapy. A lot of doctors look at this. And a lot of patients look at this. And a lot of times, doctors will say, well, if I can get your urine pH up to 7.5, they'll come across the graph and say, you'll be able to keep 600 milligrams of cystine in the urine, and that's how I'm going to guide your therapy. And it's a very wise way to approach it. But I do want to tell you that graphs like this are completely are fairly misleading. I don't want to say completely, but fairly misleading, because it looks like a single line, and it looks like an absolute truth. There's a ton of scatter. If you plot out the individual points that make these kind of lines, there's a lot of scatter around here. Can I go to the next slide? Well, here's a set of data. David showed you a different set of data from my lab. This is an earlier set. That same red line I just showed you was superimposed. Everyone's different. Yes, there's a general trend that the higher the pH in the urine, the more soluble cystine becomes. But there's a tremendous amount of scatter. There's other factors besides pH that affect solubility. And so at pH 7, some people are tremendous solubility, and pH 7, other people's not very good solubility. It's not an absolute link. It's a general trend. The higher pH, the greater the solubility. And so one of the things we did at Lip Lake was say, we should measure the solubility rather than just guessing at it, and that's what we do. And so our goal here is to help to guide therapy by actually measuring solubility rather than trying to guess at it from a group average. Next slide.